Welcome to the Peds Hub podcast. We are a group of paediatric trainees in the Southwest who every month review a selection of articles that we find useful for our practice.
These are taken from the BMJ Archives of Disease in Childhood journals.
For the full articles, please go to their website, journals.bmj.com. Please note, these are our own opinions and are produced for educational purposes only. They are not intended to substitute professional medical advice, diagnosis, or treatment.
Thanks for listening.
Hi, I'm Felicity Cooksey. I'm a paediatric registrar working in the Severn Deanery. Today, we're going to be talking about a short report published in the June edition of Archives of Disease in Childhood. It's titled A New Model to Deliver Scheduled Outpatient Care by Tiffany Martin and her colleagues. I feel very fortunate to be joined by Dr. Sarah Bridges, a paediatric consultant working in Musgrove Park Hospital in Taunton. Dr. Bridges helped to set up an integrated model of care for paediatric services in Taunton, and her team's work is referenced in the article we're discussing today. So welcome, Dr. Bridges. How are you today?
I'm good, thank you. Thank you for inviting me, and it's great to sit in your tent of blankets and things to discuss.
Well, can you tell those listening a little bit about yourself?
Yeah, so I'm a general paediatrician at Musgrove Park Hospital. Many of you will probably already know me and the stuff that I do here. I've worked here for 20 years as a consultant. My passion is the primary-secondary care interface because I feel it's work in that area that's going to change paediatrics dramatically in the next sort of 10 years or so.
Well, thank you so much for adding your expertise. It's really welcome. The report that we're talking about today is for a team working in NHS Grampian who changed their model of providing outpatient paediatric care to an integrated child health model. So my first question is, what do we actually mean by integrated child health service? And I know it's something you advocate for, so why do you feel it's beneficial?
So there's probably hundreds of definitions and there's not one agreed definition at the minute. For me, it's about, at the minute, children are either seen in primary or secondary care or seen by social care or CAMS. It's all very much different services and different discrete teams. Integrated care for me is about having the child or the family at the centre, and then the rest of us all run around the outside providing whatever support and help they need. And there's not so much distinction between being in primary or secondary care.
That's really helpful, thank you. Are there any models where social and education services are also being integrated?
So everyone's trying that. It's all challenging at the minute because of financing and staffing and what time is available. But there's various different models evolving in different places, but it's very much work in progress at the minute. Each area has got slightly different demands and needs, so they're all evolving along slightly different routes at the minute.
It was interesting, as part of the reading for this, I read the health policy team for the RCPCH has written the case they're investing in integrated child health services for the acutely unwell child and long-term conditions. And they said that they estimate a quarter of GP workload is comprised of the paediatric population, but less than half have had specific paediatric training.
Oh, absolutely. And I think that's getting worse rather than better. One of the biggest initial referrals we were getting was children with UTIs for the investigations, which are all set out in NICE. And as consultants, we were sat here thinking, well, why aren't the GPs able to do this? When you actually crunch down the numbers, you realise a GP will see one child with a UTI every year. It's not in their interest to maintain skills in that area for one child every year. And we realised that if we could work together in making it much easier for both the patient and the primary care staff.
Yeah. And could you tell us a little bit about the model of care which you set up in Taunton? I appreciate there have been changes because of COVID.
Yeah. So I'm going to talk about how it was set up pre-COVID. The reason we began to do it is I did some work on lean thinking. So do you know what lean thinking is? So lean thinking is where you come up with a problem, and the problem I had was the journey from patient and family being worried about a particular symptom or condition to getting the answer they needed from a consultant. Then you write every single step that family needs to go through in order to actually get the answer they need. So for a child or a family to actually come and see a paediatrician and get an answer, there's about 50 steps. So it's like you go to your GP, you speak to your GP, the GP refers to the referral management centre, the referral management centre requests an appointment, the paediatrician reads the referral, the paediatrician agrees an appointment, puts them in a clinic. Patient gets in the car, drives to the car park, and so on, right down to making up the notes, nurses weighing and measuring, coming into the clinic. They then get to see the paediatrician. You have your discussion. There's a whole tail of other steps then about dictating your letter, approving your letter set being sent out, being uploaded to the GP practice. So the first step in lean thinking is, as I see it anyway, is just writing out all those steps. And then you circle the steps that add value to that patient journey. So with this particular example, the steps that add value are the consultation with the GP and the consultation with the paediatrician. All the rest is sort of guff around those two added value steps. And then you create a new pathway with just those added value steps. And that's where our idea about the primary care clinics came from. So the way the process would work is the family would have gone to a GP. They would have gone with a problem that the GP wasn't quite sure of the answer. The GP would then email me the referral letter. I'd say, yep, that looks good. I need to see them in primary care. So of all the referrals we get in, we had the chance of initially just writing back with an advice management plan, seeing them in a primary care clinic, actually in the GP surgery, or a specialist clinic in hospital. You need that because occasionally you might get someone referred with celiac disease or with epilepsy who needs to see the specialist team. The GPs would book them into a clinic in primary care. They would take complete charge, their admin teams, of booking them in. We'd have half-hour slots for new patients, which mirrored exactly what we had in hospital. We'd see 8 patients in a clinic. Every 2 months for each GP cluster, we'd run a clinic. I would go out to that clinic and I would sit in a clinic room with a member of the GP practice. And that varied. It could be a GP themselves. It could be a practice nurse. But for governance processes, we quickly learned we needed someone from the practice. We'd see all 8 patients. Then at the end of the clinic, I'd run a meeting with all the staff in the surgery. So it would be the health visitors when they were in surgery, the practice nurses, the GPs, and we'd go over every single child we'd seen in that clinic and all the other referrals that I'd had in the previous 8 weeks that we'd done written management plans for. And that was quite a massive chunk of the added value because there's constant CPD and learning then for the GPs. When they had the confidence that I was going to be there every 8 weeks, often they wouldn't worry about referring a patient because they'd know I was going to be there and they would discuss it at the meeting that I was running. And so it was really essential part of the whole process in bringing down the referral rate.
And it sounds really similar to what Tiffany Martin and her colleagues
I did discuss with them before they set up their clinic because
really?
I think they were like looking for ideas and trying to, understandably, not reinvent the wheel and actually build on what we'd started.
Oh, brilliant. Well, they're based, as I mentioned, in NHS Grampian, and their report was specifically 2 areas, Aberdeen City and Aberdeenshire, the surrounding area of Aberdeen City. They tell us in their report about how they integrated paediatric outpatient services, and they, similar to you, used this cluster clinic model of care.
We clustered GP practices into groups where their referral rate was 100 a year because we knew we could manage that within a clinic that was running every 8 weeks, so alternate months. And for some practices, it meant all you did was a surgery. They were just a one practice cluster for the bigger ones. Yeah. For the smaller ones, there might be 2 or 3 practices clustered together, and then we'd rotate where we actually did the clinic. And we had an agreement from the GP surgeries that we could see patients from other practices in their surgeries. And it seemed to work well.
So for Tiffany Martin and her colleagues, they used 10 clusters. They completed a pilot first in one of the clusters, and they outcomed their referrals to either sending a letter back to the GP, speaking to a parent, arranging a clinic appointment, or referring to another speciality. Speaking to a parent could have been to arrange an investigation. It could have been to ask the parent for more information, such as asking for a photo. A second consultant vetted the outcome decision blind. Once a month, a clinic was held in one of the GP cluster surgeries, and they had a GP with an extended role and the local paediatrician who led those consultations and met before and after the clinic, and in a similar way to you, reflected on the cases afterwards. Their child's GP was asked to complete any prescriptions, and they collected feedback from the parents and referring GPs in that 3-month period. The pilot cluster was between 2018 and 2019, and then it was extended across Aberdeen City in April 2019. They performed a differences analysis between the Aberdeen City referrals and the Aberdeenshire referrals, and they also clusters. They completed a pilot first in one of the clusters, and they outcomed their referrals to either sending a letter back to the GP, speaking to a parent, arranging a clinic appointment, or referring to another speciality. Speaking to a parent could have been to arrange an investigation. It could have been to ask the parent for more information, such as asking for a photo. A second consultant vetted the outcome decision blind. Once a month, a clinic was held in one of the GP cluster surgeries, and they had a GP with an extended role and the local paediatrician who led those consultations and met before and after the clinic, and in a similar way to you, reflected on the cases afterwards. The child's GP was asked to complete any prescriptions, and they collected feedback from the parents and referring GPs in that 3-month period. The pilot cluster was between 2018 and 2019, and then it was extended across Aberdeen City in April 2019. They performed a differences analysis between the Aberdeen City referrals and the Aberdeenshire referrals, and they also audited any patients re-referred into the service to detect any missed pathologies. So on to their results. So the pilot included 205 referrals, 54%, so 110 were seen in clinic, and of those seen in clinic, 70% were discharged after one appointment. A quarter resolved with a letter, and a fifth had onward referral. How does that compare to your experience?
Yeah, it's fairly similar. So we have much bigger numbers. So for over the time we've had like 4,000 or 5,000 seen in this way. And our figures are generally quite comparable to a similar service that's happening in London, the Connecting for Child Health Service. So if you imagine all the referrals into us from a GP, and of course this, as soon as you start doing a primary care clinic, you instantly change what the referrals look like. But if I take it from the first year, as soon as if you imagine every referral in, about 40% can be managed with a written management plan. And the more you get to know your GP practice and your GPs, actually the more management plans you can write, because you have a better relationship really between the two of you. But in general, 40% could be managed by a written management plan. 40% could be managed by seeing in primary care and not needing to come up to the hospital. And you're left with about 20% that need to come up to the hospital. So they are the group that either need to come up straight away for a specialist clinic like epilepsy or gastro, or those that you initially saw in primary care clinic and then it became apparent they might have an underlying long-term condition you need to refer in for specialists.
It's interesting how many patients we could prevent needing to come to hospital.
And that's a massive thing for the trust, because quite often our service in primary care peds, or our service in general paediatrics and seeing patients, do you know what the new patient tariff is? Do you know what the CCG pay? So they pay £250. It varies from region to region, but in the average is about £250 for a new patient appointment. So for every child that comes in and is seen by us, it costs the CCG £250. So an 8-patient clinic would cost the CCG classically £2,000.
Oh, wow.
And of that, only 5% is the paediatrician's cost. All the rest, the non-added value stuff that we put around this.
I didn't appreciate how little the paediatrician's time would be.
Well, it's because it's the process which is so important.
Yeah.
And when you realise that, you realise there's other ways of doing this.
It must be better for the patient and the family, as you say, in terms of missed time from school, work,
absolutely.
travel time.
Our feedback
parking.
with the families absolutely loved that. The parking was always a major thing, and our DNA rate was massively less in the hospital because they knew their surgery and they knew how to get there. There wasn't any of the transport issues. In addition, it made them trust their surgery more because they were aware that a paediatrician was working with their surgery. So when a GP said, "No, I'm not worried about this. I will discuss it with Dr. Bridges when she comes," and it just got that buy-in much, much, much better. Many patients didn't realise it was a new service. So getting feedback from it was difficult, because they were like, "Well, you've always seen my baby. You saw my baby at 8 weeks when there was a worry about a clicky hip. And then you saw them at 3 months when I was vomiting." They just think it's part of the normal GP service. So it was quite difficult getting formal feedback.
Yeah, because in this pilot process where they tried to collect feedback, actually it looked like it was less than 10% referred did give feedback from a patient perspective.
Yeah.
It sounded like they did have a good response from GPs though, and the feedback was largely positive. But I suppose those who are choosing to give feedback, it's
really
a self-selecting
hard,
group.
Yeah. I mean, the GPs really liked it, and the staff in the practice really liked it. And I encourage, the admin teams and everyone to come to the clinical meetings, because it's really helpful, them all understanding how our process worked. And I don't think there's any rocket science here. This was just creating relationships between pediatricians in secondary care and GPs in primary care, because to have actual conversation between two people is quite hard at the minute.
Yeah.
But actually putting us in the position to enable that, it allowed us to create that and evolve the clinic with each practice cluster.
Yeah.
So everyone wanted it in slightly different ways. So one of our clusters, the Minehead cluster, was run by one of our juniors at the time, because I needed to make sure it wasn't working just because it was me. I had to make sure that it would work if other clinicians were running it. I wanted to make sure that trainees still managed to get trained in seeing first referrals, because the way we'd initially set up the model, it avoided any juniors being involved at all. And it was Claire, one of our colleagues, who did that clinic. And I asked for some feedback from some of the GPs about how it was going. And I was delighted, but also slightly disappointed they preferred Claire. And when we and Claire will laugh at this, but when we tried to work out why that was, it's because they felt more able to ask a registrar questions without feeling stupid. There's this, you don't want to lose face by speaking to another consultant, but they liked her style.
Oh, that's really lovely. We'll have to send this to Claire. After they had done their pilots, they then expanded it out, and for their 2019-2020, the number of referrals they managed in the cluster clinic model was 2,615. The proportion of patients being seen in clinic dropped from 72% to 56%, with a greater proportion of referrals being managed by letter, which is similar to your experience.
And I think it's just creating those relationships.
Interestingly for them, I'm just noticing that the number of referrals was slowly increasing. So they had a 10% increase in referrals over the 3-year time period.
Yeah, so interesting. That's a national thing that everywhere has seen this 10% increase year on year.
One of their points is that they'd said that trainees were yet to be included. It was great when pre-COVID were able to include trainees. How do you think this model of care will affect trainees in the future?
I mean, there's no doubt this model of care suits particular personalities and particular trainees in the same way oncology suits particular people and neonates. So what we need to be really skilled at is matching the right personality to the right jobs, which is something in medicine we're learning about anyway. But for people who've got an interest in it, first of all, we're looking at whether we can set up sort of spin training, because it is a particular skill, being able to manage and safety net in this way. It's different from what we're used to doing in paediatrics. But we also have to make sure that we have the right supervision for staff. We can't just send them out to GPs and expect them to get on with it. They do need to be able to come back to base and talk through and discuss the cases, a bit like as you would do in a normal general paediatric clinic.
And if we talk a bit more about finances, which this report doesn't go into, it sounded like there was a real cost benefit.
Yeah, so there's massive cost benefits for the CCG, because they would save a lot of money if we're not seeing patients in hospital. So it would mean that the hospital would get significantly less funding.
Okay.
So that might have implications for your management teams if suddenly you're creating a service that's creating less income. But the issue is, what I had to discuss is that running the service is much cheaper in this way. So you don't have any of the secretarial, the admin, the nursing, the outpatient use, because you're able to go out to primary care and use their facilities. So we actually agreed a contract with the CCG where we'd charge them half the standard tariff for seeing the patients in primary care. So for every 8-patient clinic, the CCG made a saving of £1,000. So they were obviously gagging for it. I was also aware was for that £1,000, the actual profit margin of that £1,000 was more than if we'd seen 8 patients in hospital. So the profit margin was more. So our trusts were like, yeah, great, just do it. I was lucky at the time because I had worked on the CCG as not our local CCG, but another CCG as a secondary care rep. So I was aware of the processes and what we had to do. And it enabled some of these conversations to happen a bit easier.
Most of our listeners
are paediatric trainees. So what would be your top piece of career advice?
think my advice is we're privileged to do the job we do. Sometimes we don't realise that when we're being called right, left and centre. And it's just to make sure that each day you make a human connection with another human being, whether it be a baby, whether it be a staff member, whether it be just somebody in the corridor. If you can make that human connection, it makes your life feel that it's been a useful day. And often the things that make you make that human connection are not the high-powered clinical skills that all of you have got. It's the old man in the corridor saying, oh no, how do I get to the prostate clinic? You go look at the map together to work out how to get there. And that's the thing that you remember at the end of the day. And we are privileged to be in this position to be able to make so many human contacts each day. And it's just recognising that and how it makes us feel you make that contact. So on bad days, it can be hard to think, why am I doing this job? But you just have to think, okay, hang on a minute. Let me just think what I've done today.
That's a great piece of advice. And thank you so much for joining me today. And thank you to our listeners. I hope you all enjoyed learning more about integrated childcare. Please comment on our website and let us know your thoughts and any feedback you have. Thank you.
Bye.
Hello, my name is Dan Leach. I'm a paediatric ST6 working in Bristol, and I'm also the current Peds Subtech Fellow. The paper I selected to review is from the June issue of Archives and is called Daytime Urotherapy in Nocturnal Enuresis, a randomised controlled study. I chose this article because nocturnal enuresis is a very common issue seen in general paediatric clinics, which most of us will have encountered. First, a little background. From a developmental perspective, we expect children to be dry overnight by the age of around 5 years. At around 4 years, about 20% of children are wet overnight, about half of them at least twice a week. By 9.5 years, this is reduced to 8% and 1.5% respectively, although this clearly still represents a significant number of children. As well as being a common problem, nocturnal enuresis impacts on the self-esteem and quality of life of children and young people, as well as placing additional pressure on parents and family relationships. Many children with nocturnal enuresis also suffer with daytime wetting, and in this group, overactive bladder or detrusor overactivity may be the underlying cause. This group with concurrent daytime wetting were excluded in this paper, in order to specifically look at children who experienced only nocturnal enuresis. The underlying cause in these cases is typically either nocturnal polyuria, excessive production of urine at night time, and or a high arousal threshold, resulting in failure to wake when bladder is full. I referred to the NICE clinical guideline, CG 111, which is called Bedwetting in Under 19s, as being representative of current UK practice. This recommends provision of advice on fluid intake, diet, toileting patterns and reward systems. It goes on to describe the use of either enuresis alarm systems and or desmopressin. It says, offer an alarm as the first-line treatment to children and young people whose bedwetting has not responded to advice on fluids, toileting or an appropriate reward system. In short, NICE recommends that treatment should be commenced if basic bladder advice, also known as basic urotherapy, has been ineffective. Previous studies assessing the response to basic bladder advice have generally shown modest improvements, but lack control groups which make the finding non-generalizable. The purpose of this study was to establish if basic bladder advice was effective at reducing nocturnal enuresis, in comparison to alarm therapy or no treatment. Now on to the study population and methods. 60 children completed the study, this number being based on a power calculation which the authors performed, although not all the specifics for this are provided. As previously mentioned, children were excluded if they experienced daytime wetting, or if they had received previous treatment or had a suspected confounding disorder. The children were aged between 6 and 10 with a mean of 7.2 years, and further population data are provided by the authors. They randomised the children into 3 groups using a virtual sealed envelope protocol. Group A received basic bladder advice. The authors provide details about the specific topics covered, which included advice on establishing proper drinking and voiding habits. This was delivered over an 8-week period by a paediatric nurse and urotherapist, with follow-up phone calls at 2 and 6 weeks. Group B received enuresis alarm treatment over the same period with the same follow-up contacts, and Group C received no active treatment. The primary outcome measure was the reduction of the number of wet nights between the 2-week period immediately before treatment and the final 2 weeks in the 8-week intervention period. Before treatment, the median number of wet nights in a 2-week period was 12.5 for Group A, 11.0 for Group B, and 12.5 for Group C. The corresponding figures for the last 2 weeks of the intervention period were 11.5 for Group A, that's the group receiving basic bladder advice, 3.5 for Group B, that's the group receiving the alarm therapy, and 12.0 for Group C, which was the group receiving no treatment. This is shown with a striking forest plot in the article itself, which is worth a look, but the numbers are clear regardless. The number of wet nights for basic bladder advice and the no treatment arms are practically unchanged. The median number of wet nights over 2 weeks for the alarm group fell by 7.5, from 11 to 3.5 nights. P-values are almost unnecessary in this case, but they were 0.44 for the basic bladder advice group, less than 0.001 for the alarm therapy group, and 0.55 for the no treatment group. The authors also performed comparisons between the study groups and demonstrated a statistically significant differences between the alarm therapy group and each of the other groups, whereas there was no significant difference between basic bladder advice and no treatment at all. Before we rush to dispense with bladder advice for all children with nocturnal enuresis and just give out an enuresis alarm every time, there are a few limitations to consider. First, as previously mentioned, this study excluded all children with daytime wetting. Actually, I think this was a good move by the authors, with the rationale that the underlying pathology tends to be different between these groups. By examining the effectiveness of interventions for children with and without daytime wetting separately, we're more likely to be able to find treatment approaches that work for each group, rather than trying to create a one-size-fits-all strategy. But we must remember not to try and generalise these findings to all patients with nocturnal enuresis. By that argument, we can also say that it may be that a subgroup of these patients in fact would benefit from basic bladder advice. The initial consultation for a child with nocturnal enuresis should undoubtedly include assessment of current drinking and voiding habits. If these are already in keeping with what we would advise, then logically basic bladder advice would be unlikely to be effective. It would be interesting to see if a subgroup analysis of patients who met some threshold for poor drinking or toileting habits would derive benefit from basic bladder advice. Finally, it's important to recognise, and this is highlighted by the study authors, that basic bladder advice includes developing effective motivational relationships with patients, giving clear explanations regarding underlying causes, and dealing with guilt and family dynamics. These aspects of practice should always be part of consultations relating to nocturnal enuresis, and the findings of this study should certainly not suggest otherwise, even if a formal programme of bladder advice is de-emphasised. In conclusion, I don't think this article suggests that the existing NICE guidelines are incorrect, but it would change how I weigh the different treatment options. For children with nocturnal enuresis without daytime wetting, and in the absence of major drinking or toileting behavioural problems, this study would support a clinician in seeking to move immediately to enuresis alarm treatment. This would likely expedite improving patient and family satisfaction and reducing demand on resources for avoidable follow-up appointments.
That's all for this episode. As always, if you have any questions or comments, please feel free to get in touch via our email address podcast@pedshub.co.uk or via the PedsHub website. Equally, if you'd like to get involved, we always welcome your voices, so please do get in touch.
Thanks for listening.